This conference will now be recorded.
Good morning all. Am I audible to you? Am I audible? Am I audible, Sia? Someone respond. Sushmita, am I audible? Likita.
Yes, ma'am.
Okay, thank you. So today's topic is about dysmenorrhea. Coming to definition, dysmenorrhea literally means painful menstruation. Painful menstruation of sufficient magnitude so as to incapacitate day-to-day activity. So this pain will be that severe that woman cannot do her day-to-day activity, then we'll call it as dysmenorrhea. There are two types of dysmenorrhea. First one is primary and second is secondary dysmenorrhea. Primary means without any identifiable pelvic pathology. In this dysmenorrhea, there is no identifiable pelvic pathology, whereas secondary dysmenorrhea is it is associated with the presence of organic pelvic pathology. So by treating this organic pelvic pathology, we can treat the secondary dysmenorrhea. So coming to clinical varieties, there are three types: spasmodic, congestive, and membranous. Spasmodic dysmenorrhea means most prevalent and manifests as cramping pains, generally most pronounced on the first and second day of menstruation. Whereas congestive dysmenorrhea manifests as increasing pelvic discomfort and pelvic pain a few days before menses begin. So spasmodic dysmenorrhea generally occurs on first and second day of menstruation, whereas congestive dysmenorrhea it occurs few days before menses begin. This is due to increased blood supply to the pelvic organs before menstruation. The patient rapidly experiences relief in the symptoms once she gets menses. This variety is commonly seen in PID, IUCD bearers, and pelvic endometritis and fibroids. Whereas membranous dysmenorrhea, this is relatively rare and it runs in families. It is a special group in which endometrium is shed as a cast at the time of menstruation. The passage of the cast is accompanied by painful uterine cramps. This is a rare variety and it usually runs in families. Coming to primary dysmenorrhea, without any identifiable pelvic pathology, incidence, this is more common type, more than 50%, and age group is 18 to 25 years. Patient profile is predominantly confined to adolescent girls, usually appears 6 to 12 months after menarche. Mother or her sister may be dysmenorrhea. Coming to etiology, most common cause of primary dysmenorrhea are due to prostaglandins. In ovulatory cycles, there will be progesterone, and the progesterone will induce prostaglandin synthesis. Whereas in anovulatory cycles, there will be no progesterone and no prostaglandins. So anovulatory cycles are generally painless cycles. These prostaglandins in turn induce sensitivity of nerve endings and cause pain. These prostaglandins cause increased uterine activity, that is uterine contractions, which in turn reduce blood flow, causing uterine ischemia, and also it also causes pain by sensitizing nerve terminals to prostaglandins. So this is the phenomena by which primary amenorrhea will occur in these age groups of 18 to 25 years. Behavioral and psychosomatic, tension and anxiety during adolescence lower the pain threshold. Dysmenorrheic mother usually has a dysmenorrheic daughter, single child. Imbalance in the autonomic nervous control of the uterine muscle, overactivity of sympathetic nerves, hypertonicity of circular fibers, and internal loss. If this is the cause, once the patient had normal delivery, usually the circular fibers will be destroyed and the dysmenorrheic cycles will be stopped. For this, we also tried for dilatation of the cervix artificially to destroy the circular fibers and to stop the hypertonicity of the circular fibers. Abnormal anatomical and functional aspects of myometrium, uterine dysperistalsis and hyperactivity, role of vasopressin and endothelins similar to prostaglandins. Coming to symptoms and signs, pain begins a few hours before or just with the onset of the menstruation. Duration, severity of the pain usually lasts for few hours, may extend to 24 hours, but seldom persists beyond 48 hours. So usually pain resolves in first 2 days. Pain is spasmodic, colic in nature and confined to lower abdomen. Radiation to the back and medial aspect of the thighs is common. It never extends below the level of the knee. Systemic discomforts like nausea, vomiting, fatigue, diarrhea, headache, and tachycardia. Rarely syncope and collapse in severe cases may be associated. Coming to investigations, we should find out hemoglobin levels by doing CBP and ESR. ESR is to rule out endometritis and subacute PID. NAT for gonorrhea and chlamydia. Pelvic ultrasound if not relieved by medication. Management, general measures and drugs and surgery. These are 3 modes of management. Coming to general measures, reassurance, improvement of general health, regular physical activity. In majority of the cases, nothing more than general advice, reassurance and empirical relief of pain are necessary. In case of severe cases, the drugs are used like prostaglandin synthesis inhibitors, also known as NSAIDs, reduce the prostaglandin synthesis and direct analgesic effect, usually used orally 1 to 3 days starting with the onset of the period. Usually there is no need of NSAIDs after 3 days because pain dysmenorrheic cycles only last for first 2 days. Continuous therapy during the period gives better results than administration on as needed basis. 4 to 6 months course of therapy is warranted for determine the response for the treatment. These are the NSAIDs: indomethacin, ibuprofen, naproxen, ketoprofen, mefenamic acid. Generally, with out of all this, we routinely use mefenamic acid 500 mg twice daily. Contraindications are gastrointestinal ulcers or bronchospastic hypersensitivity to aspirin. Side effects usually mild and include nausea, dyspepsia, diarrhea, and occasionally fatigue. Coming to antispasmodics, hyoscine. This is also known as buscopan and rotin. We generally don't use these drugs routinely. First, we try with mefenamic acid. If it don't subside, then we'll go for these second line of drugs. Oral contraceptives. Suitable candidates are who wanted contraceptive precaution with heavy periods and unresponsive or contraindicated to anti-prostaglandin drugs. Coming to action, it inhibits ovulation. This is the main action of oral contraceptives. If it inhibits ovulation, there will be anovulatory cycles which are painless. So automatically pain relief will be there. This also decrease endometrial proliferation and reduce heavy periods. Advantages are regularity of the periods, modest bleeding, desired contraception treatment of choice in many young women, and dydrogesterone. This also used alternative to the progesterone, OC pills, who need consumption. So this does not inhibit ovulation. This interferes with ovarian steroidogenesis. Should be taken from day 5 of the cycle for 20 days. Continued for 3 to 6 cycles. Other drugs are codeine. This is non-pharmacogenic pain management. Other treatments like heat, acupuncture, and acupressure. Transcutaneous electrical nerve stimulation. This is a new modality. And abdominal electrical or chemical heating pads. Herbal and dietary therapies, vitamin E, mineral proteins, and fatty acids. Coming to surgeries, this is surgeries reserved for only intractable cases. Intractable cases means we have tried everything available, but we cannot treat this dysmenorrhea in the patient, then we'll go for surgery. Laparoscopic uterosacral nerve ablation. Laparoscopic presacral neurectomy, dilatation of cervical canal, injection of pelvic plexus, injection of anesthetic drug into this pelvic plexus, and laparoscopy. This is the management protocol. But first, we have to give assurance, analgesics, and antispasmodic drugs to empty the bowel and encourage normal activities. If these general measures fails, then we'll go for OC pills, depending if no contraindication for prostaglandin synthesis inhibitors, presence of contraindication of pill, patient wanting pregnancy, then we'll go for prostaglandin synthesis inhibitors, that is NSAIDs, for 3-6 cycles. If patient wanted contraception, then we'll go for OC pills. If there is no contraception for either, but both the treatment fail, then we'll go for ultrasound or laparoscopy to exclude pelvic pathology. Then we'll go for a surgical management, as this is intractable case. Dilatation of cervix, laparoscopy, uterine nerve ablation, and presacral neurectomy. This is all about primary dysmenorrhea. Then we'll go for secondary dysmenorrhea. This is cyclic menstrual pain in association with underlying pelvic pathology. Often begins with 1 to 2 weeks before menstrual flow and persists until a few days after cessation of the bleeding. Primary dysmenorrhea is only for 2 to 3 days, but secondary dysmenorrhea is a prolonged pain. Pain may be due to premenstrual pelvic congestion or increased vascularity in the pelvic organs. This is congestive dysmenorrhea. Patient profile is usually age of the patient is after 30 years and Paris. Etiology might be due to endometritis, adenomyosis, subacute endometritis, IUCDs, uterine leiomyomata, polyps, congenital malformation of uterus, Asherman syndromes, and pelvic inflammatory diseases, cervical stenosis, ovarian cysts, and pelvic congestion syndrome, and Allen-Master syndrome, broad ligament varicocele. These are the different causes of secondary dysmenorrhea which are associated with pelvic pathologies. Secondary dysmenorrhea might be unilateral or bilateral. In some cases which are rare, the secondary dysmenorrhea might be unilateral. Cases like ovarian dysmenorrhea, bicornuate uterus, unilateral rotation of pelvic endometritis, small fibroid polyp near one cornu, right ovarian vein syndrome, and colonic or cecal spasm. Coming to signs and symptoms, pain is dull, no radiation, starts 3 to 5 days prior to the period and relieves with the onset of menses. Onset and duration depends on the pathology, no symptomatic discomfort. Coming to investigations, we do CBP and ESR, pelvic ultrasound, microbiological cultures from endocervix or peritoneal fluid in suspected PID, histosalpingogram, laparoscopy. Laparoscopy is single and most useful diagnostic procedure. MRI is best for diagnosis of congenital uterine anomalies. Coming to management, treat the underlying cause. As secondary dysmenorrhea is always due to pelvic pathologies. If you treat the pelvic pathology, automatically dysmenorrhea will resolve. So symptomatic management with the NSAIDs and OC pills. Pelvic endometritis may be treated with increasing dose of diazole, OC pills, GnRH and antagonists. IUCD users select an alternative method of contraception. Rudimentary horn, we go for excision. Diagnostic hysteroscopy followed by dilatation and curettage, excision of polyp or uterine septum. dilatation of cervix, it damages the nerve endings and results in dysmenorrhea. Diagnostic laparoscopy followed by lysis of pelvic adhesions, myomectomy, drainage of chocolate cysts, cautery and laser vaporization of islands of endometriosis, excision of adnexal masses. Other treatment modalities are LUNA, that is laser-assisted uterosacral nerve ablation for spasmodic dysmenorrhea, laparotomy followed by excision of chocolate cysts, eradication of endometriosis, myomectomy, excision of localized adenomyoma, presacral neurectomy, and hysterectomy is in the elderly woman is the last resort. If above all treatment fail, then we'll go for hysterectomy. Transcutaneous electrical nerve stimulation is effective in 45% of the cases. So this is the plan of management. If we get a patient with dysmenorrhea, first we have to ask thorough history, associated symptoms, any medication taken or history of PID and IUCD, psychological assessment. Then we should ask whether it is related to menstrual cycle. If it is menstrual cycle, if it is not related to menstrual cycle, then we have to evaluate it as abdominal pain. If it is related to menstrual cycle, perform a detailed examination. If we get any abnormal findings, evaluate for secondary dysmenorrhea, ultrasound, HSG and laparoscopy if needed. If no abnormal findings, treat it as primary dysmenorrhea. So in case of diagnose and treat conditions causing secondary dysmenorrhea, if symptoms relieved, just follow up. If symptoms persist, then we should treat it as primary dysmenorrhea if needed for contraception. Then we'll evaluate and counsel. If not needed, trials of prostaglandin inhibitors, analgesics and hydrotherapy support and counseling. Symptoms still persist or increase, can consider presacral neurectomy or hysterectomy. So this is the plan of management of patient with dysmenorrhea. Coming to a rare variety of membranous dysmenorrhea, this is very rare. There is familial incidence. Endometrium instead of being fragmented, strips of in large pieces or even as whole cast, preceded and accompanied by severe colic. Pathogens is not clear. Generally, endometrium will be fragmented and comes out of cervix. In this case of membranous dysmenorrhea, it will not be fragmented and it gets strips off and will be shedded in large pieces. Does not interfere with conception and pregnancy. Not cured by childbearing. Refracted to all treatments including curatives. Suppression of ovulation by means of ossipills, administration of cyclical ossipills for 1 to 2 years is said to be effective in some cases. This is a rare variety. Thank you. Are there any doubts in this topic? This is a very small topic and also important because we'll get more cases of dysmenorrhea in gynec OPD. So all of you know what is the cause of dysmenorrhea and types and how to treat. Any doubts? Okay, then I am ending the meeting. Thank you all.